Good morning, and thank you very much for this kind invitation to share with you some of the data that we are working in. I'm going to discuss briefly with you some of the ideas about using the MRI, the late enhancement MRI, to localize fibrosis in the atrium, and what does it mean and what does it help. Is it working? Which one is the green one? Yeah. Okay, well, sorry, one back, please, yeah. So this is an excellent review that was performed a few years ago by sorry, back one, what I'm touching? Ah, yeah, this is back, yes, and this, okay. So this excellent review was performed by Hans Kottkamp a few years ago, and as you see, when we talk about low AFib, the concept is that sometimes it's just an electrical problem, that there are triggers in the pulmonary veins, and it's AFib in itself what is creating afterwards the structural remodeling. But I think nowadays it's clear that there's a structural remodeling before having atrial fibrillation, and even in these histological studies performing biopsies taken during surgery, you can see that those having low AFib, they also have increased fibrosis when you look at the tissue. So what is the problem of trying to identify this fibrosis? Well, there are many issues here, and of course, the main technical difficulties are related to the also high image quality, the thin left atrial wall, and the limited spatial resolution. And so these imaging techniques also are influenced by the patient characteristics and a lot of difficulties. So that's why the concept has been here for many years, since Nasir Marouchai was the first to really start publishing about that. And but still there's a lot of lack of reproducibility and a lot of concern saying how good is that technique and how reproducible it can be. And of course, this slide is very well known from everybody, showing that you can classify patients by looking at the degree of fibrosis and predicting the success of atrial fibrillation ablation. This was also published in the DCAF study 2 years ago. And when you see such extensive fibrosis, whatever you do, you probably will not, you will fail, at least with catheter ablation, to restore sinus rhythm. And this is beautifully shown in the slide, showing when you have the stage 4 Utah classification, then your chances to succeed with your ablation are really low. At the same time, how can we see what is the correlation, or what is the gold standard to prove that what we see in the MRI is really fibrosis? And there's no gold standard, because we are simply comparing with voltage. There are several studies doing that. This one, for instance, did it just visually. This is the electroanatomical mapping showing low voltage areas that really correspond with the fibrotic areas that you see at MRI. And also you can try to do that in several ways. But how do we standardize that? How we do reproduce that? And this is an example that how variable can be the image that you obtain with MRI depending on the threshold that you are choosing. So this is the low voltage area that you see in those are 2 patients, electroanatomical mapping. This is using intensity ratio that is corrected by the normal intensity. This is using another technique that would be to choose 2 standard deviations over the region that you consider the normal region. This is 3 standard deviations. Those are methods that are being used in different labs, and you see that what you consider normal or abnormal, it varies, or it's critically variable depending on the thresholds, and that is not very reproducible from one lab to another lab. Though there's also some correlation between the bipolar voltage and what you see in the MRI. But this is a general vision, but what happens in a specific area, it's really hard to determine. I think there are many steps that can be, not only the acquisition of the image, but also how do you treat the image, how do you perform the segmentation, what are the image, the original measures that you choose, what do you consider normal? For instance, the blood pool, you normalize with the blood pool, you normalize with other areas in the atrium, and this is variable from one place to another. And that probably can explain the lack of reproducibility and why we are a little bit stuck in the development of all this concept. What we are using in our lab is the 3 Tesla's MRI with a specific sequence, and what you see, that you can see quite often areas of hyper-enhancement, even in just a simple view, but then you follow several steps, and the way you perform these steps will influence the final result. First of all, you obtain the MRI, but then you do a manual drawing, which is a very operator-dependent process. And also then you change that into a 3D structure, and finally you can even withdraw the pulmonary veins, whatever. So you end up having a shell that can be even fusion with your mapping system, and you can use theoretically the areas that you identify of fibrosis to guide your procedures or to identify where this fibrosis is located. In order to standardize that, we did a study that analyzed 10 normal people and young people, no fibrosis, no disease, no heart disease. And we defined the image intensity ratio that will be healthy volunteers. And we decided that over 2 standard deviations, that would be 1.20, would be the abnormal tissue. Then we also tried to separate from dense scar to intermediate lesions, and we do that in the other way around. So we took lesions that were created by ablation, and the 60% intensity of these lesions were considered the limit where the intense scar or dense scar started. So that means that I think it's very easy to identify dense scar. So when you look at post-ablation patients, you really identify scars. And I have more difficulties in seeing how can we identify areas where you have this, what you define the fibrosis that is not a dense scar, but in, how do you call that?
Diffuse endomusial.
Endomusial, I couldn't find the word. So how can we see that in an MRI? I'm not sure that you can really see that, no? But if you compare what you see in after ablation, you will see this is the purple line. You have this skewed normal curve, so this area means that you have a deviation, you have a lot of fibrotic dense scar here. You have some intermediate situation here with patients with persistent or paroxysmal. Those are not long-standing persistent. Those are very healthy patients because those are patients that went for ablation. And then you have the normal. That's the narrow curve. And so there's some differentiation, and that's what we are using to identify these areas. That would be an example of a patient pre-ablation, and you see that you identify areas around the left. This is a posterior view, and this is the left pulmonary veins, and you see these areas of fibrotic tissue. But it's true that in many patients with paroxysmal atrial fibrillation, we see almost no lesion with the MRI. And that can be that it's an early stage within the mesial fibrosis that you can really not find with this technique. No? Of course, there's some correlation with voltage. So the lower the voltage, the higher the intensity ratio. This is the shell that we obtained the MRI. This is the voltage, and then you can fuse that in the same image in the navigating system. And those are some examples. And this is it also goes with the comments that Dr. Cox has made about what the electrophysiologists call a line. So we probably, if you consider that a line, that's you are very geometrically very deformed, because it's really not a line. It's a very extensive lesion what you are doing. No? So, but it's just an example on how you can see the patient before. The patient had very, very small. This is a mitral valve, so there's almost no fibrotic tissue here. Whereas after the ablation, you can see what you have done, and you have done an extensive scars. Okay, so if we call that cosmetic PV isolation, this is not true. We are doing much more than that. No? One study that we performed a couple of years ago was to try to guide the re-ablation, because we are convinced that the MRI is helpful seeing the lesions we have created. Try to guide the re-ablation by using the MRI. And then this study was performed in 15 patients, but nowadays we are using systematically as a help, as another tool when we remap our patients. And what you see is that you can really identify areas where you have gaps. No? So it really helps in directing the reablation procedures, because it's really very clear when you have done, what you have not done, and you can go back and just burn there to complete the lesions that you did in your first step. No? Another thing that we are investigating, and I don't want to stand too much, we have reported that in Hart last year, but it's still, we are writing a paper, and it's interesting because what we realize is that the fibrotic tissue, it's at the beginning, at the paroxysmal patients, almost always start in this area around the left pulmonary veins and the posterior wall. So there's not homogeneous distribution in the fibrotic tissue. It's really localized in different areas. And when we analyze that and we divide the atrium in several segments, that would be the left posterior and left inferior areas around the inferior pulmonary vein. And well, that's the process of analyzing that. So there's a fusion of the MRI with the software, etc. There's an engineering work on that that analyzes exactly that, where the fibrosis is located and the percentage fibrosis in each segment. This is something performed with a system, with a special software. But you see that in segments 3 and 5, you concentrate a lot of fibrosis as opposed to other segments. So, and we have to have in mind that this is patients that underwent AFib ablation, so it's relatively healthy atrium. It's not long-standing persistent. So, but it's true that it seems that the fibrosis is starting in this area, and we don't know much about that. One hypothesis is when you look at the MRI, what's crossing there is the aorta. So I don't know if it's really a mechanical issue that when you have hypertension or whatever and the aorta is pressing against the atrium, you are creating a lesion there. I don't know why, but it's true that it seems that fibrosis is starting and in this area, curiously. Another thing that you can use this system is also to compare the lesions that you are doing with one energy or another energy. For instance, so we have compared the laser patients with RF patients in this series. And well, we see that probably the recurrence rate was quite similar at 6 months follow-up. That's 21%. But the number of gaps you see was much lower. Gap-free veins, 25% have no gaps as compared to H3. But it means that in RF patients, when you look at the MRI, only about 10 or less than 10% of patients have 0 gaps. And after being done the complete isolation, blah, blah, blah. So when you look at the results that you have done a lot of things, you have burned a lot of things, but achieving at least through the vision of the MRI complete no gap, it's 10%. So we have to rethink in our mind what we are doing with these patients. Really, it's as Dr. Cox pointed before. Probably it's not exactly PV isolation, but many more things that are acting here and making these things work. Those are just an example showing that the lesion that you create with laser is much smaller and focused, sometimes even too deep into the vein, because it's hard to know where you are burning with the laser. It's just a balloon and will depend on the diameter. Whereas when you do the RF, you do much extensive lesions. So what the things show here that even with less extensive lesions and more specific lesions, you can get more or less the same results in terms of clinical recurrences, etc. So I think there's a lot of discussion, because the way we deliver the energy and how selective we are can be modified. And if we're using laser, for instance, we can be much more specific than using RF. But is it wise? Is it not? I mean, we need some more information on that. We can also compare cryo with RF. In this series, we have compared 30 patients and 30 match controls, and well, you see more or less there's not much difference in terms of results. There were less in the RF. There were more gaps as compared to cryoballoon, but the extension of the lesions is quite similar in both systems, with some more gaps seen in the RF technique as compared to cryo, at least according to the image. So this is not an electrical gap. Those patients were not recatheterized, were just studied by MRI. Okay. So I think that we can summarize that MRI is a good tool to analyze lesions post-ablation. Different techniques produce different lesion characteristics. Laser more localized, RF less localized, more gaps, more antral, cryoballoon less localized, similar gap, etc. And let me finish with 3 minutes. This is a patient that a colleague from our hospital is a physician that we did a couple of weeks ago, and how different and how difficult it is to decide before ablation how sick is the atrium. And that is we only have indirect measurements when we see a patient for the first time. How sick is this atrium? And probably, of course, if it has been in long-standing persistent, this is a very important information. If you have a huge dilated atrium, it's important information. But then there are other issues, that other patients you cannot know in advance. This is a 58-year-old physician that was sports in his young age, but now is a bit obese and hypertensive. And he find the atrial fibrillation. He was asymptomatic. He just find incidentally. So we really do not know how long it has been there. Apparently, a physician should know how to take the pulse, but we are not sure. He's not a cardiologist. So maybe he's been there for more time than for months. Interestingly, and there's a strong family history of persistent AF with 2 brothers having persistent AF and both dying suddenly at 57 years old, a sudden death. This is, though we exclude Brugada and other long QT, but there's this strong family history of atrial fibrillation. And just wanted to point that the atrium was not so dilated. So apparently it was a recent onset AFib with a not very dilated atrium. And so we performed there's a small septal hypertrophy. But when you perform, well, this is especially for Yuri, because he's analyzing the electrocardiogram, and you see the electrocardiogram has very low voltages. This is an indication that really the atrium is sicker than should be probably for the clinical history on this patient. And when you look at the MRI, you will see that this, first of all, is very spherical. So it's not very large, but very spherical and deformed. So it's almost a sphere. And this is what we measure also the sphericity, that we showed also that this is a concept, how close is to an spheric shape, it tells you how sick is the atrium also. But if you look at the degree of fibrosis that you see in this particular patient, it's huge. I mean, there's almost no voltage in the posterior wall. This is MRI, but also when you look at in the voltage, you see that there was a very low voltage. And well, this is the carto mapping in AF. Even in AF, we were able to demonstrate low voltages, and also the MRI here. And well, what we did our best. We did the PV isolation, and then we tried to create something box that, of course, the surgeon will laugh on that and say, it's at the end in this area we couldn't find any voltage. That's what we did, and we restored Cyrus rhythm. But this is 2 weeks ago, so I'm not very confident. But just the example on how difficult it is to see in advance how sick is the atrium, and if I have to bet on that, I would say that probably it will have recurrences simply because, because it's very extensive and fibrotic process that we don't know why is here. Maybe the patient has been many months or years in AFib, I don't know. So I think that to summarize that, MRI is a promising tool both to determine the extension of fibrosis and to guide ablation procedures. It could be used to evaluate atrial disease even before it has appeared, atrial fibrillation has appeared. So theoretically can help you to guide upstream therapy, for instance. And I think that's all from my side. Thank you very much.
Thank you very much, Louis. We have time for one or two short questions. Laurent, please.
Louis, thank you for an excellent presentation. I have actually two questions for you. Looking at these MRIs for the left atrium, do you think there is a certain amount of fibrosis in which we should refrain from ablation? That's the first question. And the second question is, why don't you look at the right atrium?
Yeah, I will start by the second one. We haven't had time. So, I mean, theoretically, you can, we have the right atrium, so it's just a matter of devoting some people working on that. We start doing that, but we haven't analyzed that. And this is a very good question, because as Dr. Cox said, we probably are completely focusing in the left atrium simply because it's where we know what to do. And if we go to the right atrium, we don't know what to do, except doing an extensive line that probably cannot be done with catheter effectively. You know? So that's why we, as electrophysiologists, try to forget about the left atrium, the right atrium, and not to look it. So we are starting to analyze these MRIs, but have no data on that. And the second question, I think it's more and more clear that at least for catheter ablation, those patients with very extensive fibrosis process, whatever the atrium is dilated or not, have very low chances to be cured by catheters. So I would not recommend to do this type of ablations by catheter alone. Or at least you know that if you just do some PV isolation, you will have recurrences almost 100%. So that's something that we have to take into account and decide whether these patients have to go for a surgical procedure, what to do with these patients.